You know, we all take it for granted that blood just gets to our brain, powering everything we do. But here's something to really wrap your head around. Tiny variations in the route those critical arteries take can have huge consequences, sometimes requiring surgeons to perform incredibly intricate workarounds. Okay, let's unpack this because it's more complex than you might think.
It really is. What's fascinating here is how these subtle anatomical differences, they're almost like blueprints for the surgeon. It completely dictates their strategy when they're dealing with blood flow issues in the brain. It's never a one-size-fits-all situation.
Exactly. And that's precisely what we're diving depth into today. We're focusing on how surgeons actually get access to these crucial blood vessels supplying the head and neck. Our guide for this exploration is the very detailed Rutherford's Vascular Surgery and Endovascular Therapy textbook. Think of this as getting the insider's view on the complex anatomy and the clever surgical moves needed to reach these vital arteries.
Right. These chapters are like the surgeon's detailed roadmaps. They lay out all the different surgical routes and the critical anatomical landmarks they need to consider for, well, all sorts of different scenarios.
And for you, our listener, this deep dive is a chance to really appreciate the incredible precision involved in this type of surgery. We're going way beyond just knowing the arteries are there. We're going to understand the landscape and the strategic why and how behind the decisions surgeons make to safely get to these critical vessels. It's kind of like seeing the incredibly detailed planning that goes into a major construction project.
Precisely. We're lifting the hood, so to speak, to understand the fundamental principles that guide these incredibly delicate operations.
So where does this amazing network of arteries even begin its journey to the brain? Where's the starting point?
Okay, so it all starts with the aortic arch. Think of that as the main central highway, where blood leaves the heart. From there, three major roads branch off, heading towards the arms and the head. On the right, the first branch is the innominate artery, then you have the left common carotid artery, and finally the left subclavian artery.
And that first branch, the innominate, it's like a really short on-ramp that splits again almost immediately, right?
Exactly right. The innominate artery, sometimes also called the brachiocephalic trunk, has a very brief run before it divides into two main arteries. The right subclavian artery, which heads out to the right arm, and the right common carotid artery, which goes up towards the right side of the head.
Okay. Now, those vertebral arteries, the ones that are super important for supplying blood to the back part of the brain, where do they usually join this arterial highway?
Typically, the vertebral arteries branch off the subclavian arteries, usually just a little bit after the subclavian leaves the aortic arch. However, and here's where it gets really interesting, their starting point can actually vary quite a bit from person to person.
Oh, tell me more. How much variation are we talking about? Like, what kind of surprises might a surgeon find?
Well, quite a few, actually. On the left side, the common carotid artery, that main vessel heading to the left side of your head, could sometimes actually sprout from that first branch, the innominate artery, before then veering over to where it's usually located on the left.
Ah, okay.
And on the right side, the vertebral artery might sometimes emerge as part of a three-way split, a trifurcation of the brachiocephalic trunk, alongside the common carotid and subclavian arteries. And on the left, in some cases, the vertebral artery can even spring directly from the aortic arch itself, that main highway coming right out of the heart.
Wow, that's a surprising number of variations. It's almost like nature likes to keep surgeons on their toes.
Hmm.
So if a surgeon is expecting to find an artery in one place based on the textbook anatomy, these variations could really throw them off if they aren't carefully reviewing the patient's imaging beforehand.
Precisely. And that's not all. There's also the possibility of what's called an aberrant right subclavian artery. In this case, the right subclavian artery arises further down the aortic arch, actually after the left subclavian.
After the left.
Yeah, and then it has to loop back across the body, usually behind the esophagus and trachea, to reach the right arm. Quite a detour.
Okay, so once we navigate past these initial segments and potential variations, we then reach the common carotid arteries on each side of the neck, right? Those are the main ones we think about.
Yes, the common carotid arteries, one on the left and one on the right, then travel upwards in the neck within a protective sleeve of tissue called the carotid sheath. Their journey continues until just below the jawline, where each one splits into two main branches, the external carotid artery, or ECA for short, and the internal carotid artery, or ICA. Think of the common carotid as a main road split into two separate highways.
And that ECA, the external carotid, it has its own set of important smaller roads branching off it, doesn't it? Supplying the face and scalp and so on.
It does. Key branches of the ECA include the superior thyroid artery, which is interesting because it can sometimes even originate directly from the common carotid artery itself, not the ECA.
Really? Another variation.
Yep. There's also the ascending pharyngeal artery, which runs very close to the superior laryngeal nerve, a relationship surgeons have to be extremely careful about during surgery in this area. Then we have the lingual and occipital arteries, both of which have a close association with another important nerve in the neck, the hypoglossal nerve.
Yeah.
Think of these ECA branches as supplying blood to the face, scalp, and other structures in the neck, the more local road network branching off the main carotid highway.
Now, what about the ICA, the internal carotid? Does it have any of its own branches in the neck?
No, and what's really important to remember here is that the internal carotid artery has absolutely no branches whatsoever in the neck. Its entire mission is to head straight up towards the brain to deliver blood there. Nothing branches off before it gets inside the skull.
Got it. And we can't forget those specialized little sensors located right at that fork in the carotid artery, can we? The carotid sinus and the carotid body. They sound important.
Absolutely crucial. The carotid sinus, nestled right in the angle where the common carotid splits into the ECA and ICA, is like a tiny blood pressure gauge. It senses changes in blood pressure and immediately sends that information back to the brain via a nerve connection, the sinus nerve of Herring, which comes from the glossopharyngeal nerve.
Okay.
The carotid body, another small structure right at the same fork, acts like a chemical sensor, constantly monitoring the levels of oxygen and carbon dioxide in the blood. It also communicates with the brain via that same sinus nerve of Herring. These are incredibly sensitive areas that surgeons have to handle with the utmost care to avoid triggering unwanted reactions, like changes in heart rate or blood pressure during a procedure.
Okay, so we've got the basic roadmap laid out. Now, what happens before the surgeon even makes the first cut? What's the preoperative game plan to get the patient ready for surgery, specifically something like a carotid endarterectomy or CEA?
Right, so preoperative preparation for CEA and CEA is a really common surgery where they clean out plaque buildup from the carotid artery, typically involves putting the patient under general anesthesia.
Hmm.
Now, while some surgeons might choose to use local anesthesia or a cervical block to just numb the area,
Right, keep the patient awake.
yes, but general anesthesia offers several advantages.
Such as what? Why go for full anesthesia if local is an option?
Well, general anesthesia can actually help to increase blood flow to the brain and, importantly, reduce the brain's need for oxygen and nutrients during the surgery, its metabolic demands. Plus, it ensures the surgical team has complete control of the patient's airway, which is vital, and it really helps to ease any anxiety for both the patient and, frankly, the medical team.
Makes sense.
And in some more complex situations, like when the blockage is very high up near the skull base, or if it's a redo surgery, they might even use a special type of intubation through the nose called nasotracheal intubation, just to help get better access to that higher area.
Okay. And getting the patient positioned correctly on the operating table seems equally important, I imagine.
Absolutely critical. The patient is usually placed flat on their back, supine, with their head gently turned away from the side that's being operated on. They also slightly extend the neck by placing a small rolled-up towel or blanket behind their shoulder blades, a shoulder roll.
Okay.
The operating table itself is often tilted just a little bit so the patient's head is slightly higher than their feet. That's called a slight reverse Trendelenburg position.
And what's the reason for that slight head-up tilt?
That small incline, it just helps to reduce the pressure in the veins in the neck, which can minimize the risk of venous bleeding during the surgery. It's also standard procedure to continuously monitor the patient's blood pressure directly inside an artery throughout the entire operation, intra-arterial monitoring.
And the prep area. How wide an area do they clean?
Oh, it's quite extensive. The area that needs to be cleaned and prepped for surgery stretches from the jawline and the lower edge of the ear all the way down to below the collarbone, the clavicle.
Right. And I remember reading something about a squeeze toy. That seemed like an interesting detail for when they don't use general anesthesia.
Yes, that's a clever technique that's used when the patient isn't fully under general anesthesia, but instead has a regional block. A small squeeze toy is placed in the patient's hand on the side that isn't being operated on, the contralateral hand. This allows the surgical team to regularly check the patient's brain function during the procedure by simply asking them to squeeze the toy. If they can still move that hand, it gives the surgeons reassurance that blood flow to the brain is being maintained adequately while the carotid might be clamped.
That makes perfect sense. A really simple but effective way to monitor things in real time. Okay, now let's get into the real nitty-gritty, actually getting to that extracranial carotid artery for the CEA surgery. What are the typical incision options a surgeon might use? How do they start?
Well, there are two main types of incisions that are commonly used. The standard approach involves a cervical vertical incision. This is basically a straight cut made in the neck, running parallel to and just slightly in front of that big muscle you can feel on the side of your neck, the sternocleidomastoid muscle, or SCM.
Okay.
This incision is usually centered right over the point where the common carotid artery divides into the ECA and ICA, the carotid bifurcation.
And this standard incision, it can be made longer or adjusted depending on the specific situation, right? Like if the blockage is higher or lower.
Exactly. It offers great flexibility. It can be extended further up towards that bony bump behind your ear, the mastoid process, if the blockage, the lesion, is higher up, or it can be extended downwards towards the top of your chest bone, the sternal notch, if the problem lies lower down in the common carotid artery. Sometimes, the very top of the incision might be gently curved backwards, just behind the earlobe, to avoid that salivary gland near your jaw, the parotid gland.
Gotcha. What about the other option? I remember reading about an oblique incision, one that's more angled, maybe follows a skin crease?
Yes, the oblique incision is made along a natural crease in the skin right over where the carotid artery splits. The main benefit of this type of incision is that it often results in a scar that people feel is less noticeable and therefore, more cosmetically appealing compared to the vertical incision.
Okay, that makes sense. But there have to be some downsides if the vertical cut is still considered the standard. What are the trade-offs with that angled incision?
You're right, there are trade-offs. The oblique incision can sometimes make it more difficult for the surgeon to get additional access to the arteries if they suddenly need to work further up or down the neck during the operation. Also, this type of incision often requires the surgeon to lift flaps of skin to get a good view, which adds an extra step to the procedure.
Ah, okay.
So while it might look a bit better afterwards, it can sometimes limit the surgical flexibility. Think of it this way. The vertical incision is the workhorse maximum visibility, very adaptable for complex cases. The oblique is often preferred when cosmesis is a significant concern, and the anatomy seems pretty straightforward on imaging. Each choice balances access with aesthetics.
Right. Okay, let's walk through the standard vertical incision then. Once that initial cut is made through the skin, what are the key layers and steps the surgeon takes?
Okay. After the skin is cut, the dissection continues downwards through the platysma muscle, which is a very thin layer of muscle just under the skin in the neck. Surgeons often use electrocautery, a tool that uses electrical current to cut tissue and simultaneously seal blood vessels to help control any bleeding during this step. It's quite common that a vein called the external jugular vein will need to be divided as they go deeper. Also, there are several small sensory nerves in this area that belong to the superficial cervical plexus. These nerves might also need to be divided, and this can sometimes lead to temporary numbness or reduced sensation around the incision site afterwards.
And there's a specific nerve higher up that the surgeon needs to be particularly careful of, right? Near the ear.
Yes, exactly, the great auricular nerve. It might be visible if the incision extends higher up towards the ear. Surgeons try their best to protect it if possible, gently retract it. However, if it does end up being divided, it can cause some numbness in the earlobe, although this usually gets better within a few months. Also, right at the angle of the jaw, the surgeon needs to be very careful to stay on the outer side and avoid accidentally dissecting into that parotid gland we mentioned earlier.
Right, the salivary gland. Got it.
Once the surgeon is past these more superficial layers, what's the next key landmark they're looking for? The dissection continues along the inner border of the sternocleidomastoid muscle until they reach the carotid sheath. Think of the carotid sheath as a protective sleeve of fibrous tissue that surrounds the common carotid artery, the internal jugular vein, and the vagus nerve, three very important structures all bundled together.
Okay.
The common carotid artery is then gently freed up, mobilized for a good length, especially around the area where the blockage is located. To get better control of the common carotid lower down in the neck, a thin muscle called the omohyoid muscle might be divided, and any small blood vessels in that area are carefully tied off.
And then the focus shifts to carefully separating out the ECA and the ICA, right? Getting control of those branches.
Exactly. The dissection proceeds upwards to carefully isolate the external carotid artery and its various branches. The internal carotid artery is also mobilized until the surgeon reaches a point where the vessel looks healthy and normal beyond the disease segment. Sometimes, the surgeon might inject a small amount of local anesthetic, like lidocaine, around the point where the common carotid divides. That's called the carotid bifurcation.
What's the purpose of injecting local anesthetic there? Is that for pain?
It's actually more about preventing a reflex. That injection helps to block the nerve supply to that carotid body and sinus we talked about earlier, the ones that sense oxygen, CO2, and pressure. This helps to prevent a reflex slowing of the heart rate, known as bradycardia, which can sometimes happen when this sensitive area is manipulated during the surgery.
Ah, I see.
During this part of the dissection, a small branch of the superior thyroid artery, called the sternomastoid branch, usually needs to be tied off and divided. Other small blood vessels that supply the sternocleidomastoid muscle might also need to be cauterized to prevent bleeding.
Now, this is the stage of the surgery where there's a risk of injury to some really important nerves in the neck, isn't there? It sounds like a crowded neighborhood.
Precisely. It's a critical point. The surgeon has to be extremely careful to avoid injuring the accessory nerve, which is cranial nerve number 11. This nerve controls the SCM and trapezius muscles and can often be found in the upper part of the surgical field. Once the sternocleidomastoid muscle is gently pulled to the side, specialized surgical tools called retractors, like Whiteliner or Henlo retractors, are used to keep the tissues held back and provide a clear view of the surgical area.
Okay.
If the patient is under regional anesthesia, as we discussed, it's sometimes necessary to inject a little more lidocaine around the carotid sheath at this point to make sure they're comfortable and the area is adequately numb for the deeper work.
And what about the internal jugular vein, that major vein that runs alongside the carotid artery? How is that handled during this exposure?
Right. The internal jugular vein, or IJV, which runs right next to the carotid artery, is carefully dissected along its inner border and then gently pulled backwards or retracted laterally. This almost always requires the surgeon to divide a smaller vein called the common facial vein, which usually drains directly into the internal jugular vein right around that level.
And I can imagine that the exact layout of these veins can vary a little from person to person, not always just one common facial vein.
Yes, absolutely. The way these veins are arranged can be quite variable. There might be just one common facial vein, or sometimes there could be 2 or even 3 separate veins that join the internal jugular at slightly different points. In those cases, each one needs to be individually identified, tied off, and divided.
Okay.
The connective tissue in this area, between the facial vein and a muscle called the digastric muscle, which lies above it, is also rich in lymph nodes, which are small glands part of the immune system. These might need to be carefully separated from the vein and potentially cauterized if they're in the way or bleeding.
Now, it sounds like constantly being aware of the nerves in this area is absolutely critical for the surgeon. You mentioned the accessory nerve. What others are nearby?
It is paramount. Nerve identification and preservation is key. The dissection should always stay in front of the common carotid artery to avoid any injury to the vagus nerve, which is cranial nerve number 10. Well, the vagus nerve usually lies behind and to the side of the carotid sheath.
Usually.
Usually, yes. But it can sometimes curve forward, especially lower down in the incision, becoming more anterior. Surgeons also have to be constantly aware of several other cranial nerves in the vicinity. The glossopharyngeal nerve, number 9, the accessory nerve, number 11, which we've already mentioned, and the hypoglossal nerve, number 12, which controls tongue movement.
Wow.
And also a branch of the facial nerve, number 7, called the marginal mandibular branch, which controls the lower lip. Injury there can cause a droop. And then there's a rare but very important possibility.
A non-recurrent laryngeal nerve.
A non-recurrent laryngeal nerve. That sounds tricky. What does that mean? So this nerve, which controls the voice box, usually takes a roundabout route through the chest before coming back up to the larynx. But in some people, maybe 1% or so, it can branch directly off the vagus nerve high up in the neck and head straight across to the voice box.
That sounds like a nerve that could easily be mistaken for something else if the surgeon isn't expecting it.
Exactly. This non-recurrent laryngeal nerve can sometimes cross right in front of the carotid artery and could potentially be mistaken for part of the ansa hypoglossi, which is a loop of nerves that controls some of the strap muscles in the neck. Accidental injury to the non-recurrent laryngeal nerve would result in paralysis of the vocal cord on that side. This anatomical variation is seen more often on the right side of the neck.
Okay.
The vagus nerve itself can be very closely connected to that slightly widened section at the beginning of the internal carotid artery called the carotid bulb, and it gets very close to the hypoglossal nerve near a bony projection at the base of the skull called the styloid process. It's a real convergence point up there.
And the hypoglossal nerve itself is also vulnerable during this surgery, the one for the tongue.
Yes, very much so.
Yeah.
The hypoglossal nerve is often surrounded by small veins that need to be carefully tied off to prevent bleeding. The nerve can also be injured by too much pulling or pressure excessive retraction during the surgery, That's a common mechanism of injury.
Right.
To get better access to the part of the internal carotid artery that's further up towards the skull, the surgeon might need to divide some of the smaller structures that are tethering the hypoglossal nerve in place. These could include the small artery and vein that supply the sternocleidomastoid muscle, a branch of the ansa cervicalis called the descending hypoglossal branch, and even the occipital artery in some cases. It's a really intricate web of structures all packed into a very small space.
It really sounds like it. It's amazing they can navigate that.
It is. And we also need to consider the superior laryngeal nerve, which is typically located on the inner side medially of the internal carotid artery. This nerve then splits into two branches, which pass behind the superior thyroid artery. So there's a risk of accidentally injuring it when the surgeon is trying to get control of the blood flow in either the ECA or the superior thyroid artery.
Okay.
The glossopharyngeal nerve, as we mentioned, crosses the internal carotid artery higher up near the base of the skull. The best way to protect it is for the surgeon to keep their dissection very close to the front surface of the ICA in that area. Finally, if there's too much pulling or prolonged retraction at the upper end of the incision, it can sometimes cause temporary compression injuries to the great auricular nerve on the outer side or to that marginal mandibular branch of the facial nerve on the inner side.
So gentle retraction is key.
Absolutely. Once all of these critical structures have been carefully identified and protected, the common carotid, external carotid, and internal carotid arteries are gently encircled with soft, flexible loops made of a material like silastic. These loops can then be tightened temporarily to control the flow of blood through the arteries during the actual cleaning out of the blockage in the endarterectomy procedure.
That's a really detailed look at the standard approach, but I also remember reading about a retrojugular carotid approach. What's the thinking behind that as an alternative? Why go behind the jugular?
Yeah, the retrojugular approach offers some potential benefits, particularly when it comes to visualizing the ICA and maybe reducing the risk of certain nerve injuries or bleeding after the surgery. With the standard technique, if bleeding occurs afterwards, it's often from those smaller veins, like the facial vein that had to be divided. Also, with the standard approach, the ICA can sometimes be positioned more towards the back, which might make it harder to reach blockages that are further up. And the vagus nerve isn't always perfectly visible right away, which could slightly increase the risk of injury when placing clamps.
So the retrojugular approach is designed to try and address some of those potential drawbacks of the standard method by changing the angle of attack, essentially.
Exactly. With this approach, the internal carotid artery actually tends to be positioned more towards the front, more anteriorly. While the surgeon's view of the external carotid artery might be a little more limited initially, its origin and those superior thyroidal arteries are often easier to spot and control. Crucially, the visualization of the ICA itself is significantly improved. Furthermore, this approach avoids the need to tie off and divide those major venous structures like the common facial vein, potentially lowering the risk of bleeding after surgery, and that loop of nerves called the ansa hypoglossal is also not usually divided.
So how does the actual surgical technique differ in the retrojugular approach? Where's the key difference?
The initial skin incision and the very first steps of the surgery getting through the platysma, exposing the SEM, are exactly the same as in the standard exposure. It's when the sternocleidomastoid muscle has been gently pulled aside and the carotid sheath is exposed that the dissection takes a different route.
Okay.
Instead of opening the sheath anterior to the jugular vein, the surgeon makes an incision in the carotid sheath along the lateral border, the outer border, of the internal jugular vein. Once the jugular vein is completely freed up, it's then gently moved inwards medially using a blunt surgical tool called a retractor.
So you move the big vein inwards.
Correct. Occasionally, there might be some small venous branches coming off the back of the jugular vein that need to be tied off and divided. But the key is, the vagus nerve is then clearly visible and ends up positioned on the outer side laterally of the carotid artery, often stuck to the back of the IJV.
So by moving the jugular vein inwards, other key structures are also moved out of the way, making the ICA more accessible from this angle.
Precisely. This maneuver avoids having to divide the facial vein, the ansa cervicalis, and that bundle of small blood vessels associated with the hypoglossal nerve, as all of these structures are essentially moved inwards along with the jugular vein. This gives the surgeon a much clearer, more direct view of the internal carotid artery.
Right.
From this point onwards, the rest of the dissection freeing up and isolating the ICA, ECA, and CCA with those silastic loops and controlling the superior thyroid artery proceeds in a similar way to the standard carotid approach. However, because the vagus nerve has already been clearly identified on the outer side, it's less likely to be accidentally included or injured when the loop is placed around the common carotid artery.
Interesting.
After the plaque is removed from the artery and any bleeding is stopped, the jugular vein is allowed to return to its normal position on the outer side of the artery, and the wound is closed using the standard surgical techniques.
That's a really interesting alternative approach. Now, there's also a mention of a posterior carotid approach, but it's described as being less common. Why is that the case? What's that involve?
Yes, the posterior carotid approach, which was described by a surgeon named Dr. Bergerl back in the day, isn't used as frequently by most vascular surgeons now. It allows the surgeon to access the internal carotid artery from a different direction, from the back of the neck. So the artery is approached from the inner side of the sternocleidomastoid muscle, situated between the hypoglossal and vagus nerves.
Okay, from the back. And how does the surgeon position the patient for this posterior approach? Must be different.
Yeah, the patient is typically placed either lying on their stomach prone or on their side lateral, with the arm on the opposite side of the surgery, placed underneath their head for support. The skin incision starts as a horizontal line at the bony bump at the back of the skull, the occipital protuberance, extending towards that bony prominence behind the ear, the mastoid process. From there, it then curves downwards along the back edge of the sternocleidomastoid muscle for about 2 to 3 centimeters. The dissection then involves carefully separating the fibers of several muscles in the back of the neck: the trapezius, splenius capitis, semispinalis capitis, and longissimus capitis. Quite a few layers back there.
Wow.
A nerve called the greater occipital nerve, which runs over the semispinalis capitis muscle, might also need to be divided during this part of the surgery. After these steps, the internal jugular vein, the carotid artery, and the accessory nerve are exposed from this posterior view.
It sounds like a much more involved way to get to the carotid artery going through all those posterior neck muscles compared to the front.
It generally is, and that likely contributes significantly to why it's not used as often compared to the more direct approaches from the front of the neck, like the standard or retrojugular techniques we discussed.
Right, okay. Now, what happens when the blockage in the carotid artery is located higher up in the neck, closer to the base of the skull? That must present its own unique set of challenges for surgical exposure. Getting way up there seems tough.
Absolutely. Getting good access to these high carotid lesions near the skull base, requires some specific techniques to extend the surgical field further up towards the skull, beyond where you'd normally stop.
Okay.
With the standard anterior approach, one key maneuver is to carefully mobilize and protect the hypoglossal nerve, cranial nerve 12. This often requires the surgeon to divide small blood vessels, the sternomastoid artery and vein, which can sometimes form a kind of sling around the nerve, holding it down.
Ah.
Dividing that loop of nerves we talked about earlier, the ansa cervicalis, where it joins the hypoglossal, can also help to free up the hypoglossal nerve. Sometimes tying off the occipital artery, if it's crossing over the nerve, can also provide more space. These steps allow the surgeon to mobilize the internal carotid artery up to the level where the vagus nerve and hypoglossal nerve sort of meet or come very close together.
And you can get even higher.
Yeah, it's even possible to dissect a bit further up above this level by gently using a small surgical retractor or a thin vessel loop to carefully lift and move the hypoglossal nerve out of the way, but very gently.
Gotcha. And for even higher access, when the blockage is really, really close to the skull base, what else can be done?
For even more distal exposure, getting higher still, the surgeon needs to identify the accessory spinal nerve, number 11, where it enters the sternocleidomastoid muscle. By gently tracing this nerve upwards towards the digastric muscle while being extremely careful not to damage it, the surgeon can gain more reach.
Okay.
To further help with the exposure, both the internal jugular vein and the vagus nerve are often gently pulled inwards, medially, essentially lying over the top of the carotid artery in this higher region. The superior laryngeal nerve, which branches off the vagus in this area and passes behind the ICA, also needs to be carefully identified and protected. Just above this level, a structure called the superior cervical sympathetic ganglion, which is part of the sympathetic nervous system, will become visible.
And it sounds like that digastric muscle we mentioned earlier also plays a role in accessing these high lesions. It sort of crosses over things up there.
It does. It's a key landmark. Depending on how much exposure is needed, the posterior belly of the digastric muscle, which lies above the carotid artery bifurcation, can be either gently pulled out of the way, retracted, or even divided.
Divided. You can cut that muscle.
Yes, if absolutely necessary for exposure. If it needs to be divided, this should be done very carefully using a sharp surgical knife, a scalpel, rather than with electrocautery. This is because using heat from electrocautery could potentially damage the glossopharyngeal nerve, number 9, which runs nearby and is crucial for swallowing. Injury could lead to difficulties with swallowing afterwards.
Right.
Even when just retracting these structures, the digastric, the surgeon needs to be very cautious to avoid causing any nerve injury from stretching or pressure. The glossopharyngeal nerve itself runs on top of the ICA and underneath the ECA in this region, and it can sometimes appear as a single trunk or as 2 separate branches. If the digastric muscle needs to be divided, it should be done close to where it attaches to that bony prominence behind the ear, the mastoid bone. If even more mobilization of the carotid artery is required, the styloid process, that small pointed bony projection we talked about earlier at the base of the skull, can actually be carefully cut through or fractured near its base.
Oh, fracturing bone to get access. That sounds like a really extensive procedure. Are there situations where even those measures aren't quite enough to get the necessary access, like the absolute highest lesions?
Yes, occasionally. If the surgeon anticipates needing very, very high access to the internal carotid artery right up at the skull base, this should prompt them to consider using general anesthesia with that special type of intubation through the nose, nasotracheal intubation, and crucially, to have a preoperative consultation with an ear, nose, and throat ENT specialist.
Why the ENT consult?
Because, in some very rare and extreme cases, a controlled subluxation, which is essentially a partial and temporary dislocation of the mandible, the lower jawbone, might be necessary to provide the required surgical access. This involves gently moving the jaw forward and out of the way.
Whoa.
Yeah. This is a more complex maneuver that requires very careful planning and coordination between the vascular and ENT surgical teams. Definitely not routine.
Okay. Moving on to a slightly different approach, I noticed a section in our materials about mini incisions for carotid endarterectomy. This sounds like a move towards less invasive surgical techniques, maybe better cosmetic outcomes?
Exactly. Short transverse and longitudinal incisions for both of those main types of CEA, the aversion endarterectomy and the standard patch endarterectomy, have become more popular in recent years. The main driver is often to try and reduce scarring and improve how the scar looks afterwards, the cosmesis.
And how do they compare in terms of results?
Interestingly, studies have generally shown that the medical outcomes for the patient, things like stroke risk and the overall time the surgery takes, are often very similar to what's achieved with the standard longer incisions. So you're not necessarily compromising safety for a smaller scar.
That's good to know. Let's talk about that short transverse incision first. How is that typically performed? Is it just a shorter version of the oblique one?
Pretty much. For a short transverse incision, it's really helpful to use duplex ultrasound imaging before the surgery. This allows the surgeon to precisely locate and mark the skin directly over the point where the carotid artery divides, the bifurcation.
Okay.
If ultrasound isn't used, the incision is usually made in a natural crease in the skin at about the level of the upper edge of the cricoid cartilage, which is part of the voice box. And it's made on the inner side of that big neck muscle, the sternocleidomastoid. The length of the incision is usually around 4 centimeters, maybe a bit less, although it can be made a little longer if the surgeon needs a better view. After the platysma muscle, that thin neck muscle is divided across. 2 self-retaining surgical tools called retractors are placed at roughly 90-degree angles to each other to hold the tissues apart. The rest of the dissection is then carried out in a similar way to the standard carotid exposure we already talked about. These self-retaining retractors typically provide about 1.5 to 2 centimeters of surgical field on each side of the carotid bifurcation.
So, with such a small opening in the skin, how do surgeons manage to get enough access to work deeper down on the artery, like placing clamps?
That's where smaller, specialized surgical instruments come into play. Small bulldog clamps, which are essentially miniature versions of vascular clamps designed to be placed deep within the surgical wound, allow the surgeon to gain temporary control of the carotid arteries at a level that extends beyond the actual limits of the skin incision. This applies to both these short transverse incisions and the longitudinal mini incisions as well.
Makes sense. What about the longitudinal mini incision? How does that compare to the short transverse one? Is it just a shorter vertical cut?
Basically, yes. For a longitudinal mini incision, duplex ultrasound is also very useful before the patient is prepped and draped for surgery to identify and mark the carotid bifurcation and the planned line of the skin incision. The length of this incision can vary a bit more, typically ranging from about 2.5 to 5 centimeters, depending on things like how deep the bifurcation is under the skin and how extensive the plaque is.
Okay.
The actual dissection and the way the surgeon gets to the carotid bifurcation are essentially the same as with the standard, longer longitudinal incision. The use of two self-retaining retractors, combined with the natural looseness, the laxity of the skin in the neck, allows for some pulling and stretching of the tissues. This lets the surgeon expose a longer segment of the carotid arteries than the actual length of the skin incision itself might suggest.
It's amazing how these smaller incisions can still provide adequate access for such delicate work. Now, shifting gears again, what happens when a patient needs to have carotid surgery for a second time? Maybe the narrowing comes back. That reoperative exposure must come with its own set of unique challenges. Scar tissue, right?
You're absolutely right. Reoperative procedures for recurrent carotid stenosis, meaning surgery to treat a narrowing of the carotid artery that has come back after a previous operation, definitely carry a higher risk of complications. And yes, the main reason is the presence of scar tissue from the first surgery.
How does the scar tissue make it harder?
Well, this scarring can make it significantly more difficult for the surgeon to identify the critical structures in the neck, the nerves, the different branches of the artery, the vein. They're all kind of stuck together. And that difficulty in identification, in turn, increases the risk of accidental injury to the cranial nerves. Much higher risk than in a first-time operation.
Yeah, I can see that.
In these situations, the surgeon also has to be prepared for the possibility that simply cleaning out the artery again might not be feasible or the best option. They might need to actually remove the previously operated section of the artery entirely and replace it with a new piece, an interposition graft.
What kind of graft?
This graft can be either a piece of the patient's own vein, often a segment of the great saphenous vein harvested from the leg, or sometimes a synthetic graft made of a material like baccarin or PTFE might be used.
And the surgeon's choice of surgical approach might also be different in these reoperative cases to try and minimize those risks, maybe avoid the scarred area.
Indeed. That retrojugular approach that we discussed earlier might actually be the preferred method for reoperative procedures in some surgeons' hands.
Why is that?
By approaching the artery from that slightly different angle, going behind the jugular vein, it can potentially reduce the need for extensive manipulation and dissection around nerves in areas that have already been scarred and disturbed by the previous surgery. This allows the surgeon to work, at least partially, in a surgical field that hasn't been previously operated on, which can make it easier and safer to identify those crucial structures.
Makes sense. Work in virgin territory as much as possible.
Exactly. Regardless of the specific approach chosen, the surgeon should always anticipate needing to expose a longer segment of the artery, both further up, distally, and further down, proximally, from the previously treated area. They need to get to healthy, unscarred sections of the vessel where they can safely place clamps and potentially connect a new graft if needed.
Okay. Let's shift gears now and talk about procedures that involve both the subclavian artery, which goes to the arm, and the carotid artery. I see a section in our materials on subclavian carotid interventions. What kind of problems do these procedures address?
Yes, these are procedures designed to address blockages or other issues affecting the arteries that supply blood to both the arm and the head. Specifically, the large arteries originating from the aortic arch, like the innominate or subclavian arteries, that can impact carotid or vertebral flow.
Okay.
These types of open surgeries initially became less common with the rise of endovascular techniques, like putting stents in the subclavian or innominate arteries from inside the blood vessel using catheters.
Right, less invasive.
Exactly. However, they've seen a bit of a comeback, a resurgence, with the increasing use of a procedure called thoracic endovascular aortic repair, or TEVAR, for treating aortic aneurysms or dissections.
How does TEVAR relate to these subclavian carotid procedures?
Sometimes, when surgeons are doing a TEVAR procedure, placing a large stent graft in the aorta in the chest, they need to cover over the origin of the left subclavian artery or other major vessels coming off the aorta to get a good seal for the stent graft. In those cases, they often need to perform a separate debranching procedure beforehand, or at the same time like a carotid subclavian bypass or transposition to make sure blood flow to the brain via the vertebral artery, and the left arm is still maintained after the subclavian origin is covered by the TEVAR graft.
Ah, okay, I see the connection. One specific surgical technique mentioned is subclavian to carotid transposition. When is that considered a good option for a patient? What does it involve?
Subclavian to carotid transposition is generally considered an ideal solution for proximal subclavian artery blockages, except in patients who have problems affecting the more distal part of the subclavian artery further down towards the arm, or if they have extensive plaque or disease in the common carotid artery itself, where simply moving the subclavian and connecting it wouldn't solve the underlying issue.
Oh.
The basic idea behind this technique is pretty straightforward. You cut the subclavian artery just beyond the point of the blockage, and then surgically connect the healthy distal end of the subclavian, we call this an anastomosis, to a healthy, disease-free spot on the side of the nearby common carotid artery. This creates a new pathway for blood flow to the arm, originating from the carotid instead of the aorta.
And the advantages?
One of the appealing aspects of this procedure is that it involves connecting just one artery to another, end to side, potentially simpler and maybe more durable than using a bypass graft in some situations.
But there's a trade-off when it comes to temporarily stopping blood flow during the connection, right?
Okay.
You have to clamp both.
Exactly. That's the downside.
Mm-hmm.
This benefit of a single connection comes with the cost of needing to temporarily clamp both the subclavian artery, distally, and the common carotid artery at the same time while the anastomosis, the connection, is being created. Because of this type of transposition is generally not recommended for patients who have previously had a left internal mammary artery, or LIMA, bypass surgery for their heart on the same side, because the LIMA graft often originates from the subclavian artery, and clamping could compromise the heart graft.
Good point.
Also, using the common carotid artery as the source of blood flow for the arm in this way has some general theoretical drawbacks, and the need for simultaneous clamping makes it particularly less advisable if the patient has a significant blockage in the carotid artery on the opposite side of their neck. You don't want to risk reducing flow to the brain from both sides at once.
Makes sense. What about patients who also need to have a carotid endarterectomy done on the same side as the subclavian to carotid transposition? Can those two procedures be performed together? Seems like a lot at once.
Yes, they can be combined. In patients who need both a subclavian to carotid transposition and a carotid endarterectomy on the same side of their neck, the transposition part of the surgery can be done first, often with the temporary use of the small, flexible tube called a shunt.
How does the shunt work here?
The shunt is inserted through a small cut, an arteriotomy made in the carotid artery at the point where it divides, the bifurcation. The upper end of the shunt is temporarily positioned lower down in the common carotid artery, below where the subclavian will be attached. After the subclavian artery has been successfully moved and connected to the common carotid, the shunt can then be carefully repositioned, moved further up into the internal carotid artery to maintain brain blood flow, while the surgeon safely proceeds with the standard endarterectomy to clear out the blockage in the carotid itself.
Clever. Okay, now let's talk about the actual surgical approach for a subclavian to carotid transposition. How is the patient positioned on the operating table, and what are the key steps the surgeon takes to get exposure?
All right. The patient is placed on their back, supine, with a small rolled-up support positioned under their shoulder blades, and their head is gently turned toward the opposite side of the surgery. It's important to avoid overextending their neck. Often the operating table will be tilted slightly into that slight reverse Trendelenburg position we mentioned earlier, head up, and both of their arms are usually tucked in alongside their body.
And the incision.
A transverse incision, typically about 6 centimeters long, is made roughly 1 finger breadth above the clavicle, the collarbone. It usually extends from the inner to the outer head of that big neck muscle, the sternocleidomastoid, SCM.
Okay.
The initial dissection involves cutting through the platysma muscle and the superficial cervical aponeurosis, a layer of fibrous tissue. A vein called the external jugular vein might need to be tied off and divided if it's obstructing the view. The dissection then needs to be carefully kept in the space between the two heads of the SCM, and importantly on the inner side, medial, of the internal jugular vein, the vagus nerve, and a pad of fatty tissue called the prescalene fat pad.
Why medial to those structures?
To get directly down onto the carotid artery and the origin of the subclavian, the common carotid artery is then carefully dissected proximally, meaning closer to its origin in the chest and isolated with vessel loops. Great care has to be taken during this step to avoid accidentally entering the pleural cavity, the space around the lungs, which could cause a pneumothorax or collapsed lung,
Right.
or stretching the vagus or phrenic nerves. The phrenic nerve controls the diaphragm, so injury there is serious.
And it sounds like the internal jugular vein needs to be moved out of the way during this procedure, retracted laterally.
Yes, the internal jugular vein needs to be gently mobilized laterally, meaning towards the side, to provide a good view for the transposition and to allow access to the subclavian artery before the vertebral artery branches off it, which is important. On the left side of the neck, it's crucial to identify the thoracic duct. This is the main vessel carrying lymphatic fluid in the body. It typically arches over the subclavian artery near its origin and joins the venous system near the junction of the internal jugular and subclavian veins.
That sounds delicate.
It is. This duct might need to be carefully tied off and divided if it's directly in the surgical field. It's important to remember that there might be just one main duct, or sometimes several smaller lymphatic channels. You have to look carefully.
Gain on the right side.
On the right side, surgeons need to be particularly careful, especially in patients who have that aberrant right subclavian artery we talked about earlier, as the course of the thoracic duct, or major right-sided lymphatics, can be different in these individuals, increasing the risk of accidental injury if you're not anticipating it. Inadvertent injury to the thoracic duct can lead to a chyle leak, a lymphatic fluid leak, which often requires a second surgery to repair.
Got it. What else gets moved?
The inner head of the sternocleidomastoid muscle and the strap muscles, which are a group of muscles below the hyoid bone in the neck, are gently pulled inwards medially, as is the common carotid artery. A vein called the vertebral vein, which drains into the subclavian vein, should be identified, tied off, and divided. The sympathetic ganglion, or chain, which is part of the sympathetic nervous system, often has nerve fibers running around the subclavian artery at this level, just on the inner side of the vertebral vein.
Right, near the vertebral artery origin.
Exactly. And injury to this sympathetic chain should be avoided if possible to prevent Horner syndrome, a condition that can affect the eye and face on that side. Droopy eyelid, small pupil.
Okay. What about controlling the blood flow in the other nearby arteries during this procedure, the vertebral and the mammary?
Good question. The vertebral artery, which branches off the subclavian artery on its upper side, and the internal mammary artery, also called internal thoracic artery, which usually branches off on its lower side, should be carefully identified and encircled with soft vessel loops. This allows for temporary control of blood flow through them, if needed during the clamping and anastomosis phases.
And nerve protection again?
Always. At the more proximal part of the subclavian artery, closer to its origin, the vagus nerve, which crosses in front, and the recurrent laryngeal nerve, which loops underneath the subclavia on the right and the aortic arch on the left before heading up to the larynx, need to be clearly identified and carefully protected. The left subclavian artery tends to be located a bit deeper in the neck than the right, which can make it slightly more challenging to access proximally before the vertebral artery branches off. After the subclavian artery has been sufficiently freed up, mobilized, the common carotid artery, which is located in the inner part of the surgical field, is dissected further to ensure there will be no tension on the connection after the transposition and to allow for proper placement of clamps for vascular control at the level of the subclavian artery.
And you have to be careful not to kink the vertebral.
Yes, care needs to be taken throughout the procedure to avoid kinking or twisting the vertebral artery after the subclavian is moved and sutured to the carotid. Finally, it's absolutely crucial to make sure that all bleeding from the cut end of the proximal subclavian artery, the part left behind, is completely stopped and secured, usually with sutures or ties, before releasing the clamps. That stump can sometimes retract down into the chest and become very difficult to reach again if it starts bleeding later.
Yeah, that sounds bad. In more complex situations, I see mention of the surgeon sometimes needing to divide part of the clavicle, the collarbone, or even extend the incision into the chest. When would that kind of extensive approach be necessary? That seems like a big deal.
It is a big deal. More proximal exposure of the subclavian artery, meaning getting to a point closer to its origin from the aorta or innominate, can sometimes be achieved by carefully dividing and removing a small inner portion of the clavicle. This could provide better access up to the point where the subclavian artery joins with the common carotid artery to form the innominate artery on the right side.
But it's rare.
Yes. This is rarely needed in modern practice for elective cases, and is usually only considered in emergency situations involving severe bleeding, like from trauma or complication, when endovascular methods are either not possible or haven't been successful in stopping the hemorrhage.
And going into the chest.
For very proximal exposure of the right subclavian artery or the innominate artery, the surgical incision might need to be extended downwards to include a median sternotomy, which is a surgical opening made down the center of the chest bone, the sternum.
Like for heart surgery.
Exactly. This might even require the surgeon to divide a large vein in the chest called the innominate vein, or brachiocephalic vein, to fully expose the more proximal parts of the subclavian and carotid arteries, as well as the brachiocephalic trunk itself where it comes off the aorta.
And on the left side?
On the left side, if the surgeon needs to get to the very origin of the left subclavian artery, directly off the aortic arch, they might need to make an incision in the side of the chest, typically an anterolateral thoracotomy in the third or fourth intercostal space.
Wow. Okay, assuming they have the exposure they need, how do they actually perform the transposition after clamping?
Right, so once the patient has been given heparin, a blood thinner, the proximal subclavian artery, if it's being divided proximally, or the diseased segment is temporarily clamped. If the proximal end is being abandoned, it's tied off securely with strong surgical thread just beyond the clamp. After this, the vertebral artery, the more distal part of the subclavian artery, and sometimes the internal mammary artery are identified, isolated with loops, or clamped, depending on the exact situation. The subclavian artery is then cut, usually at an angle, often about 1 centimeter distal to where the vertebral artery begins, ensuring the vertebral origin is preserved.
Okay.
Next, the surgeon focuses on the side of the proximal common carotid artery. This is isolated or partially clamped, using a special type of clamp, like a Satinsky clamp, that only blocks flow through part of the vessel wall, allowing some blood to continue flowing up the carotid to the brain. A small surgical cut, an arteriotomy, is then made in the side of the common carotid artery where it was clamped. This is where the connection, the anastomosis, will be made between the end of the subclavian and the side of the common carotid artery, typically using fine sutures. This cut in the common carotid should ideally be made slightly towards the back and side of the artery, posterolaterally, to better match the often larger diameter of the subclavian artery and allow it to lie naturally.
And again, avoiding kinking the vertebral.
Yes, it's crucial to make sure that the vertebral artery doesn't get kinks or bent sharply, which could happen if the connection is made too high up on the common carotid artery or if the subclavian isn't mobilized enough. Similar principles apply, by the way, when performing the reverse operation, a transposition of the common carotid artery to the subclavian artery. This might be done to treat a blockage in the very lowest part of the common carotid near its origin. In that case, the common carotid is tied off as low down as possible, then cut, and then connected end to side to the subclavian artery. This connection can sometimes be made to the part of the subclavian artery that runs behind a muscle called the anterior scalene, the retroscalene subclavian artery. Doing this requires a surgeon to extensively mobilize the common carotid artery and sometimes tunnel it behind the internal jugular vein so it can reach the more distal subclavian artery without tension.
Okay, that covers transposition. Another technique you mentioned is carotid subclavian bypass. How does that surgical approach differ from a transposition? Is it just using a graft instead of moving the artery?
Essentially, yes. Carotid subclavian bypass involves using a graft, which is usually a synthetic tube made of a material like PTFE, polytetrafluoroethylene, often Gore-Tex, to create a new pathway for blood flow from the common carotid artery to the subclavian artery, effectively bypassing the diseased or blocked segment of the proximal subclavian or innominate artery.
And the exposure, is it the same supraclavicular incision?
The surgical dissection for the subclavian part of this bypass is similar to the supraclavicular approach that's often used for thoracic outlet syndrome surgery, which aim to expose the subclavian artery beyond the scalene muscles. The incision is typically transverse, maybe extended a bit, about 6 centimeters, starting from the inner border of the clavicular head of the sternocleidomastoid muscle, roughly 1 finger breadth above the clavicle. The initial dissection through the superficial layers is similar to what we described for the transposition. The clavicular head of the sternocleidomastoid muscle is often divided to give the surgeon a better view into the deeper space. A pad of fatty tissue containing lymph nodes, called the scalene fat pad, is gently mobilized downwards and inwards and then held out of the way using a self-retaining retractor. This exposes the anterior scalene muscle.
And that muscle covers the subclavian artery.
Yes, the anterior scalene muscle lies directly over the subclavian artery in this region. It needs to be carefully divided using a sharp surgical knife after the phrenic nerve, which runs vertically right on the surface of this muscle, has been identified and gently protected, usually by looping it with a soft vessel loop.
Important nerve to protect.
Absolutely. It's important to avoid using electrocautery to divide the anterior scalene muscle because of the risk of causing thermal injury to the brachial plexus, which is the network of nerves that supplies the arm and lies just behind the muscle and artery, as well as potentially injuring the phrenic nerve itself. The muscle should be cut as close as possible to where it attaches to the first rib. The subclavian artery lies immediately underneath the divided anterior scalene muscle. A branch of the subclavian artery called the thyrocervical trunk is usually visible in this area and can be either divided if necessary or controlled with vessel loops. This surgical exposure provides an adequate length of the subclavian artery distal to the blockage for the lower end of the bypass graft to be connected, usually at a point beyond where the vertebral and internal mammary arteries originate. The other end of the graft is then tunneled under the SCM and connected to the side of the common carotid artery, usually through the same incision or a small separate one higher up.
Right, connecting the two arteries with a tube. Got it. Finally, let's delve into the surgical exposure of the vertebral artery itself, that absolutely vital vessel for the posterior circulation of the brain. I see in our materials that it's divided into different segments based on where it travels. Can you explain that classification?
Yes, certainly. The vertebral artery is traditionally divided into 4 distinct segments, based largely on a classification system that was proposed by a surgeon named Dr. Berger. It helps surgeons talk about specific locations along the artery's path.
Yeah, what are the segments?
The first segment, called V1, is the part that runs from its origin, where it typically branches off the subclavian artery up to the point where it enters a transverse process, a bony tunnel, of the C6 vertebra, the 6th vertebra in your neck.
Okay, V1 is before it enters the spine bones.
Exactly. The second segment, V2, is the part that travels upwards within those bony tunnels, the transverse foramina of the cervical vertebrae, usually from C6 up to C2. This V2 segment is not usually exposed primarily for reconstruction or to control bleeding because it's so well protected within the bone, although it can be accessed if needed.
Makes sense. What's V3?
The third segment, V3, is the portion that runs from where it exits the transverse foramen of C2, loops around the C1 vertebra, the atlas, up to the base of the skull, just before the artery passes through a large opening called the foramen magnum to enter the skull cavity.
Okay, looping around C1 and C2.
Right. And the fourth segment, V4, is the intracranial part of the vertebral artery. It starts just after it pierces the dura mater, the covering of the brain, often considered from the level of the atlanto-occipital membrane, and ends where the 2 vertebral arteries, left and right, join together at the base of the brain to form the basilar artery, which is a major artery supplying the brainstem and cerebellum.
Got it. V1 outside the bone, V2 inside the lower vertebral bones, V3 looping around the top vertebrae, V4 inside the skull. And I imagine that the specific surgical approaches a surgeon would use are quite different depending on which of those segments of the vertebral artery they need to access. You wouldn't use the same incision for V1 as for V3, presumably.
Absolutely. The surgical approach is very much dictated by the specific segment of the vertebral artery that needs to be exposed. Each segment presents unique anatomical challenges.
Okay, let's start with that first segment, the V1 segment, from the subclavian up to C6. What are the common surgical approaches for getting to that part of the artery?
There are 2 main approaches that have been described for exposing the V1 segment. The supraclavicular approach, which means making the incision above the clavicle, and the anterior cervical approach, which is more like the standard carotid incision from the front of the neck along the SCM muscle.
Okay, which one is used more often?
The supraclavicular approach is probably more commonly used, especially when the goal is to work on the very origin of the vertebral artery, perhaps to move it and connect it to the common carotid artery, a procedure called vertebral carotid transposition. This approach gives good access to where the vertebral artery originates in the subclavian.
But are there downsides?
Yes, it might require the surgeon to cut through part of that big neck muscle, the sternocleidomastoid, to get adequate exposure, and it can sometimes limit how much of the more distal part of the V1 segment, closer to C6, they can easily see.
And the other approach, the anterior cervical.
The anterior cervical approach, on the other hand, doesn't usually require cutting through major muscles like the SCM. It allows the surgeon to access the more distal part of the V1 segment quite well, all the way up to where it enters the transverse process of the C6 vertebra.
Okay. Let's dive a little deeper into that supraclavicular approach for the V1 segment first. How is that procedure typically done? You mentioned the incision above the clavicle.
Right. The patient is positioned on their back with their head turned away from the side where the surgery will be performed. An incision, usually about 6 to 8 centimeters long, is made horizontally about 1 finger breadth above the clavicle, starting near the inner end of the clavicle and extending outwards. The platysma muscle, the superficial fascia, which is a layer of connective tissue, and usually the external jugular vein are divided. The dissection is then carefully carried out in the space between the 2 parts, the sternal and clavicular heads or bellies of the sternocleidomastoid muscle.
Hmm.
Alternatively, the surgeon might divide the inner clavicular head of the SCM and then also divide the omohyoid muscle, which is another thin muscle in the neck that crosses the field.
And then you get down to the deeper structures.
Yes. The internal jugular vein is then identified, gently freed up on its inner side, and pulled outwards laterally with a retractor. Following this, the vagus nerve is identified and needs to be protected. It can be either pulled inwards along with the common carotid artery or outwards with the internal jugular vein, depending on the surgeon's preference and the specific anatomy. The dissection continues both upwards and downwards, and the space that lies between the internal jugular vein, the subclavian vein, which is lower down, and the common carotid artery, medially. On the left side of the neck, remember the thoracic duct. It needs to be identified again here as it arches over the subclavian origin. It's often tied off and divided in this exposure.
Right.
The dissection in this area is kept on the inner side, medial, of that pad of fatty tissue called a prescalene fat pad, which covers the phrenic nerve running on the anterior scalene muscle laterally. On the right side, the surgeon might encounter some larger lymphatic channels. This is not uncommon, and these channels should be carefully tied off to prevent a leak of lymphatic fluid postoperatively.
What's the next key structure?
The inferior thyroid artery, which runs across the neck in this area, is then usually tied off and divided to clear the view. After that, the vertebral vein, which typically lies in front of the vertebral artery, is identified. It often has some smaller veins branching off it that need to be controlled first. The main vertebral vein itself should then be tied off and divided, usually closer to where it joins the subclavian vein.
And then you see the vertebral artery.
Yes. At this point, the vertebral artery and the sympathetic ganglion, part of the sympathetic nervous system, are usually easily found in the angle formed by two muscles deep in the neck, the anterior scalene laterally and the longus colli medially. Remember, the sympathetic ganglion needs to be handled very carefully to avoid causing Horner syndrome. The vertebral artery is then gently separated from any surrounding sympathetic nerve fibers, and a soft vessel loop is placed around it for control. This gives the surgeon the ability to work on the V1 segment, for instance, performing that vertebral carotid transposition we mentioned, for which this supraclavicular approach between the SCM heads is often the best choice. Or they could use it for other reconstructions, like a subclavian vertebral bypass graft, although that might require further exposure of the subclavian artery after the anterior scalene muscle has been divided.
Got it. What about that anterior cervical approach to the V1 segment? You said it's more like a carotid incision. How does that differ in technique?
Right. The way the patient is positioned for the anterior cervical approach is similar to the supraclavicular approach, head turned away. However, the skin incision is made vertically, extending from the clavicular head upwards towards the area behind the jaw, along the front edge of that big neck muscle, the sternocleidomastoid, very much like the standard carotid endarterectomy incision. The initial steps of the dissection are also similar to what's done for a standard carotid artery exposure dividing platysma, mobilizing the anterior border of the SCM laterally. The upper part of the omohyoid muscle is often divided to provide better access downwards. The carotid sheath is opened, and the carotid artery and internal jugular vein are identified. The vagus nerve and the sympathetic chain lying deeper are identified and carefully protected.
How do you get to the vertebral from there?
In the lower part of the incision, the scalene fat pad is identified laterally and gently pulled to the side, which exposes the anterior scalene muscle and the phrenic nerve that runs on its surface. Medial to the carotid sheath, the surgeon identifies and then ties off and divides the inferior thyroid artery. Dividing this artery reveals the vertebral artery lying underneath it, deep in the groove between the longus colli and anterior scalene muscles.
Ah, so dividing the inferior thyroid is key here.
Yes, it's a key step in this approach. This approach allows the surgeon to easily see the entire extraosseous V1 segment of the vertebral artery, all the way from where it originates from the subclavian, though the origin itself might be deep, up to the point where it enters the transverse process of the C6 vertebra.
Okay. Now, accessing the V2 segment of the vertebral artery, the part that runs through those bony tunnels in the vertebrae of the neck, that sounds like it would be particularly challenging surgically. You said it's not often done.
That's right. Exposure of the V2 segment is indeed less common and is typically only done in situations where there's significant bleeding that needs to be controlled, maybe from trauma or during spinal surgery, and even then it's become even less frequent due to the advancements in endovascular techniques, where they can often treat these issues, perhaps with coils or stents, from inside the blood vessel.
But if you had to expose it surgically,
Because the V2 segment is encased within those bony tunnels, the transverse foramina, the only way to directly access it surgically is by carefully removing the front part of the bony arch that forms the tunnel, a procedure known as unroofing the transverse process.
And there are risks.
Yes. The vertebral artery in the V2 segment is also surrounded by a network of veins called the vertebral venous plexus, or transverse sinus. If these veins are injured, which can easily happen as they are often stuck to the artery and the surrounding bone, it can lead to significant, sometimes torrential bleeding that can be hard to control.
Okay. How do they approach this? Same incision as for V1?
The skin incision for this approach is the same as the one used for the anterior cervical approach to the V1 segment, that vertical incision along the front of the SCM, potentially extending quite high up the neck.
And the deep dissection.
The platysma muscle is divided, and the sternocleidomastoid muscle is pulled laterally to expose the carotid sheath. Then, the critical step is to mobilize the contents of the carotid sheath, carotid, IGV, vagus nerve, medially, along with the voice box and windpipe, larynx and pharynx. They are carefully separated from the tissue layer covering the front of the vertebral bodies, the prevertebral fascia.
So you retract the whole carotid sheath inwards.
Yes, medially. This exposes the sympathetic ganglia lying on the prevertebral muscles and a strong band of tissue running vertically along the front of the spine called the anterior longitudinal ligament. The sympathetic ganglia are carefully preserved, and the anterior longitudinal ligament is cut vertically along the length of the needed exposure.
Okay.
This ligament is then gently pulled to the side, exposing the prevertebral fascia and two muscles called the longus colli and longus capitis. These muscles are carefully lifted off the front of the transverse processes of the vertebrae using a surgical tool called a periosteel elevator.
Nerve roots nearby.
Yes, crucially. To avoid injuring the spinal nerve roots that come out between the vertebrae laterally, it's really important not to extend this muscle elevation beyond the outer edges of the transverse processes. Finally, access to the vertebral artery within its bony canal is achieved by carefully nibbling away at the front arch of the transverse process using a fine surgical instrument called a rongeur, exposing the artery segment by segment.
Wow, meticulous work. What about the V3 segment, that part of the vertebral artery that runs between the C2 vertebra and the base of the skull, doing that loop? When might a surgeon need to expose that segment?
Access to the V3 segment, which stretches from where the artery exits the C2 transverse foramen up to the base of the skull, was historically used mainly for two reasons: to control bleeding that resulted from traumatic injuries to the more distal parts of the vertebral artery, or sometimes to make the final connection, the distal anastomosis, in certain types of vertebral artery bypass surgeries.
But not so much anymore.
Right. With the significant improvements in transcatheter techniques using coils, stents, flow diverters, surgical exposure of the V3 segment is rarely performed today. It's become quite uncommon.
And it's delicate territory.
Yes, at this level, the vertebral artery is quite delicate and therefore more vulnerable to injury, especially in cases of trauma. In addition, it's surrounded by that dense network of small veins called the periarterial venous plexus, which can make the dissection quite challenging and bloody. If surgical exposure is absolutely necessary, it's recommended that the surgeon dissect us along a specific layer just outside the innermost layer of the artery wall called the subadventitial plane, to try and minimize the risk of damaging the artery itself.
How is the patient positioned, and what incision is used for V3?
The way the patient is positioned for V3 exposure is similar to what's done for high carotid surgery, head turned away, although some surgeons prefer to have the patient in a semi-seated position to help reduce the venous pressure in the neck and potentially minimize bleeding from that venous plexus.
And the incision?
The skin incision is typically made vertically along the front of the sternocleidomastoid muscle, starting maybe at about the level of the cricoid cartilage in the neck, and then curving backwards below the earlobe to cross over the mastoid process, sort of a hockey stick shape.
Okay.
The platysma muscle is divided. The carotid sheath, containing the carotid artery and jugular vein, is generally retracted inwards, medially, while the sternocleidomastoid muscle is pulled outwards, laterally. Sometimes partially or completely cutting through the origin of the sternocleidomastoid muscle off the mastoid can significantly improve the surgeon's view upwards.
And nerves are critical here too.
Absolutely critical. At this stage, it's vital to identify and carefully protect the spinal accessory nerve, CNX, which enters the sternocleidomastoid muscle about 2 to 3 centimeters below the tip of the mastoid bone. This nerve should be identified and gently moved forwards out of the way.
Then how do you find V3?
The transverse process of the first cervical vertebra, C1, or the atlas, is then located by feeling for it palpation. This bony landmark is where several small muscles attach the levator scapulae, splenius cervicis, and inferior oblique. These muscles cover the space between the transverse processes of C1 and C2 vertebrae, and it's in this intertransverse space that a short, about 2 centimeter segment of the V3 vertebral artery is accessible as it loops posteriorly.
So you have to divide those muscles.
Yes. These three muscles are carefully divided near their attachments to C1. And the surgeon needs to be particularly careful here to avoid injuring another nerve called the anterior ramus of the C2 spinal nerve root, which often lies on the front edge of the levator scapulae muscle. To prevent nerve injury, the muscle division is usually done over a small surgical tool like a right-angled clamp or a small retractor, which is inserted between the C2 nerve and the muscles being divided to protect the nerve. To further improve the view of the space between the transverse processes of C1 and C2 and the vertebral artery itself, the muscle fibers that are closer to the head, cephalid, are carefully removed, and the lower ends of the divided muscles are either removed or gently pulled downwards, inferiorly retracted. This opens up that window to the V3 segment.
Got it. And finally, the V4 segment, that suboccipital portion of the vertebral artery that's closest to the brain just before it enters the skull. How is that segment exposed surgically? Is that common?
Posterior exposure of the suboccipital vertebral artery, essentially the distal V3 and initial V4 segment, uses a surgical approach that's similar to the posterior carotid exposure we talked about much earlier, coming from the back of the neck. This technique is quite specialized and might be used sometimes in conjunction with neurosurgeons to treat specific problems like dissections or aneurysms that involve the very end of the vertebral artery just before or as it enters the skull.
Okay. How is the patient positioned?
The patient is positioned either lying on their stomach, prone, or on their side, lateral, often with the head fixed in a head holder. The arm on the opposite side of the surgery might be placed underneath their head for support if they're lateral. The skin incision is similar to the one we described for the posterior approach to the carotid artery, starting near the occiput and curving down behind the SCM.
And the deep exposure.
Once the internal jugular vein and the accessory nerve have been exposed deep to the SCM and trapezius muscles, the next step often involves identifying, tying off, and dividing a small vein called the condyloid emissary vein, which connects a venous sinus inside the skull, the sigmoid sinus, to veins on the outside near the occipital condyle.
Oh.
This is followed by carefully cutting through part of a deep muscle at the base of the skull called the rectus capitis posterior major or minor, which allows the surgeon to finally see the vertebral artery in the suboccipital triangle.
And the venous plexus is still an issue here.
Yes, very much so. At this level, the vertebral artery is often covered by a dense network of small veins, that same venous plexus, which requires very careful and meticulous dissection to separate them from the artery without causing significant bleeding or injuring the delicate artery wall. Eventually, with patience, the vertebral artery can be carefully dissected all the way up to the level of the atlanto-occipital membrane, which is the tough fibrous tissue that connects the first cervical vertebra, atlas, to the base of the skull, occiput, marking the transition to the truly intracranial V4 segment.
Wow, what an incredibly detailed journey through the intricate world of cerebrovascular surgical exposure. It's really driven home just how complex and how much individual variation there can be in the anatomy of these blood vessels. And the sheer level of skill and detailed knowledge required by surgeons to navigate this incredibly delicate landscape is just,
Well,
it's staggering.
absolutely. As we've seen, there's a remarkable range of surgical approaches available, and each one is specifically tailored to allow access to very precise regions of this absolutely vital network of blood vessels. The incredibly delicate nature of these procedures really underscores just how critical it is for surgeons to have a deep and thorough understanding of the underlying anatomy, including all those potential variations we talked about, and to apply the most meticulous surgical techniques to safely maintain or restore the flow of blood to the brain. It really is a testament to the incredible intersection of detailed anatomical knowledge and highly refined surgical skill.
Yeah. It's also really striking how seemingly minor anatomical variations, a slight difference in where an artery originates or a nerve taking an unexpected path can necessitate entirely different surgical strategies, or at least require significant adjustments intraoperatively. It really highlights the need for incredible precision and adaptability in this highly specialized field of surgery.
Indeed it does. And it really makes you think about how this field continues to evolve so rapidly. Well, we've spent our time today really digging into these open surgical techniques, which are still incredibly important, the methods and technologies for treating many of these same conditions from inside the blood vessels. The endovascular approaches using catheters, stents, coils, flow diverters are also constantly advancing at a really fast pace.
Right.
This leads to a really interesting ongoing discussion in the field. What will the future hold for the balance between these traditional open surgeries and the newer endovascular methods when it comes to treating cerebrovascular disease? Which approach is best for which patient, for which lesion? It's certainly an area that's worth further exploration and careful consideration as medical science continues to progress. There's likely a role for both for the foreseeable future.
That's a fascinating thought to ponder the ongoing dance, or maybe sometimes tension, between these different approaches, open versus endo. It truly is remarkable how a deep understanding of our own incredibly intricate biological plumbing system allows surgeons, using whichever tools are best, to perform such life-saving and remarkably complex interventions. Thanks so much for taking this incredibly deep dive with me today. This was fantastic.
My pleasure. It's a fascinating area, and hopefully this gives listeners a better appreciation for the complexity involved.